So you are going to die. That's going to happen to you. And you have no idea when you're going to die. You might have a sense depending on where you are in your life, or if you have a chronic disease. But you could die right now as you're listening to this. You can die tomorrow, or you could die in 20 years. You just don't know. But what we do know, what is certain, is that you right now, listening to my words and me talking, I am going to die, and you are going to die. And the chances are pretty good that you might die in an ICU, and you might die as someone like me takes care of you. So that's what we're going to be talking about today: how to die, how to not suffer, how to focus on the quality of life that you have, and not maximize the quantity of poor quality of life, which is important. So that's what we're going to do today. Might be a trigger for some people, so stay if you'd like to hear it. But you can skip till next week if this is not something that you're up to listening to right now. I also want to give another trigger warning. I probably will share stories of trauma, meaning traumatic deaths, that involve a trauma hospital and deaths from violence and maybe even deaths of young people. I might share some stories like that today. So again, another kind of trigger warning. If you want to avoid that, maybe you should skip this episode. I've seen a lot of people die, and I'm not even that far into my career. I'm a fairly young attending, and I have lost track of how many people that I've seen die or help die. One of the reasons, my motivations for going into ICU, I did an anesthesiology residency, and I didn't have to do a fellowship, and I don't have to do ICU. I don't get paid more to do critical care. There's no financial incentive to do ICU. It's the exact same pay. Like I get the exact same compensation as my anesthesia colleagues who just do anesthesia. So there's no financial incentive to do ICU for anybody. It's not a lucrative compared to other other equal professions for physicians. So one of my motivations for going into ICU is I want to help people die appropriately and help them pass away in an appropriate way and to not have them suffer. There are surprisingly many obstacles that prevent someone from dying in an appropriate way. One of them is culture, American culture particularly, and expectations of family members. These are big obstacles for individuals to pass away in a peaceful manner. So I don't know what your experience has been, but I feel like in the United States, death is not talked about a whole lot. People are terrified of dying. You may, and I'm not critical of that, but people are very scared of dying. They're very scared of the unknown, which is very understandable. And because we're scared of dying, we don't like to talk about our loved ones that we cherish. We don't want to talk about how they die. We don't want to think about how our pets die. We avoid the subject a lot, and to a fault, until it's too late and your loved one, suddenly you're sitting holding your loved one's hands. They have a breathing tube in. They can't communicate with you, and now you don't know what to do. You don't know if you should keep pushing, or you don't know if they should pass away because maybe you've never had the conversation. And maybe there's no living will, and there's not a durable power of attorney that's been set, and that you just may not know what to do, and it's because we often avoid the topic altogether. But the truth is, you can die right now. Your loved one, whoever just came in your mind right now, they can die tomorrow. I'm sorry to bring that to your mind, but it can happen, and it does happen every day to people, every single day. I've seen, a 17-year-old who's jet skiing or something, and had no idea that they had a congenital brain aneurysm, and they their blood pressure went up a little bit, and the aneurysm burst, and it went and caused a subarachnoid hemorrhage, and they are brain dead because of that, and they cannot survive. And I've sat in front of a family of 30 people with a young person like that who is brain dead, and not only is it almost nearly impossible to explain what brain death is, but they can't understand how someone so young and exuberant and wonderful is now brain dead and that they're going to die and they have to face that. And a day before they were, jet skiing. Time and time again, I take care of chronically ill patients, patients with cancer, patients with serious diseases that they know they've had for a long time, and their family members, they get so used to their family members' diseases, and they get so used to the sickness that they become desensitized to it. And there's like new normal that like, oh, they'll get admitted. They're admitted to the hospital. They'll go home in 3 days like we normally do. We'll just tune them up and they'll send them home. But sometimes there is a final time that loved one will go to the hospital, and that's the final time, and they will die. And in that circumstance, it's hard for families to understand that things have changed, and your loved one is now sicker, and they're actually dying. They're in the process of dying, and that's a huge obstacle to letting them go. This happened to me. My dad died of a terminal disease. He had pulmonary fibrosis, idiopathic pulmonary fibrosis, or he had hypersensitivity pneumonitis. Either way, he had scarred lungs. And he had it for about 3 years. He died 3 years after his diagnosis. And just talking about that kind of tunnel vision, so he got sicker and sicker over the course of his disease, over the course of 3 years. And I remember a few months before he died, we went to my sister's wedding, and he at that point he was able to get upstairs, but that night he couldn't even walk up a flight of stairs. We had to carry him up a flight of stairs. And, we all just got so used to him being so sick that we didn't realize wait, this is new. And he had a pulmonary embolism. We took him to the hospital like 2 days later, and he had a blood clot in his heart. And it's just because we got so used to his sickness that we didn't even see when it gets worse. And that happens. That definitely happens to people. So how do I, as an ICU doctor, how do I know that a patient is nearing death? That's a complex question to answer, isn't it? For one thing, we don't know for certainty. I can't say, 100% I know this patient's going to die. However, when we believe a patient is approaching death, on average, we are very good at knowing when that's going to happen. There are certain disease processes that when they come to a head, we know that with pretty good accuracy that as soon as we withdraw care, that patient probably will die within minutes to hours, depending on what's going on. So how do we know? What does that look like? This is what I really want you to take away from this episode. Someone who's critically ill in the ICU that we believe are dying, and we believe that we should stop care as their care team, what does that patient look like? I want to describe what that patient looks like for you. So a critical ill patient that looks like they may die soon, they are typically in multi-organ failure. One by one or at once, their organs are shutting down. So what do we mean by that? So all of your organs can show signs of that they're dying, that they're ceasing to work. So your kidneys, you stop making urine, you stop clearing solutes from your body, which what I mean by that is like potassium and other salts in your body. Like your potassium starts going up, which is very dangerous. If you have high potassium, you can go to cardiac arrest. Your liver starts failing. All of these liver values start getting deranged. Your liver produces clotting factors, and if your blood starts to not clot as well, that could be a sign that your liver is going into failure, amongst other things. The lungs can be in failure. You're on a ventilator. You're not oxygenating well. You're not able to clear your carbon dioxide. Your heart can be in failure. It doesn't pump as well. You can get what we call a stress-induced cardiomyopathy, where just by being critically ill, your heart can get weak. Your bowels can go into failure. They can get less blood supply to them. They can start to die, which is a sure sign that someone is very likely going to die. Your brain can go into failure. You become delirious. You don't know who you are. You're confused. You can't communicate with family members. There are many. It's a constellation of findings when someone is in multi-organ failure. Now, if someone is in multi-organ failure, it doesn't mean that they're necessarily going to die. You can recover, right? The body can recover from multi-organ failure. And that's actually one of the amazing things about medicine that sometimes we don't realize is in medicine, we actually don't do that much. What we do in critical care, for the most part, with exceptions, we stabilize the body and let the body heal itself. It's the body that gets you out of what's going wrong. We give the body time. That's kind of what critical care is. So just by being in multi-organ failure, that doesn't mean you're going to die, that this patient's going to die tomorrow, or that we're going to be like, we should stop care. And another thing I want to make clear here, sometimes I hear people say, not a lot of people, but some people that don't work in medicine, and it's always people that do not work in medicine, they're under the impression that we do everything we can even in an inappropriate way to keep people alive because it's profitable, because it's lucrative. That's just not true. And I've worked at many different hospitals, and I've never observed this once, anytime, with anybody. When we believe a patient's not going to survive, we always advocate that we should stop care. That is always our motivation. We do not want patients to suffer when we believe their prognosis is terrible. And if you're a healthcare provider, you are with. I can hear you. You know exactly what I'm saying. But if you're non-medical, believe us. It is us that it is rarely us that is obstructing a patient to pass away peacefully. Okay, so it's multi-organ failure that maybe someone's going to die, and then it's the trend. Are they getting worse or are they getting better? That's huge. And some of the things we look for are how many interventions are we providing to keep this person alive? Okay, so there's many ways to measure this. So if someone is in shock, which shock is where your body can no longer and your heart and your blood vessels can no longer perfuse your organs, and your blood pressure can be low. If you're on a lot of what we call vasoactive medications, or just pressors, we call them, epinephrine, norepinephrine, these are synthetic, adrenaline. It's called adrenaline in the UK. Vasopressin, dobutamine, dopamine, angiotensin 2, isoprotenolol. There's a lot of these medications that we call them vasoactive. They help your heart pump. They help your blood vessels stiffen up so that we keep your blood pressure up. So if someone is on like 3 or 4 of those and their blood pressure is still low, that is an extremely dangerous situation. So that's a way to gauge how sick is this person? How many pressors are they on? So if someone is trending in the wrong direction, they're needing more and more and more support, that might be a sign that they are approaching death, that the body is shutting down irreversibly. How much support are they getting through a ventilator? So if they have a breathing tube, how much oxygen are we delivering? Is it 30%? Is it 50%? Is it 100%? If someone's requiring 100% oxygen, that's a sign that they're in respiratory failure. The lungs are not working. How compliant are their lungs? Meaning, how easily can we ventilate them? Are we having trouble ventilating them? Do they keep dropping their oxygen saturation? That's another sign that someone is trending in the wrong direction. Are they needing dialysis? Are they going into kidney failure? Is their urine output going down? Is their heart going into heart failure? Do we get an echo and we see that their heart is not squeezing as well? A lab that also can help us to see how someone is trending is the lactate. So just backing up a little bit, what is a lactate? So your cells, every cell in your body uses oxygen to produce energy. And that oxygen is delivered by your bloodstream. And that bloodstream is delivered by your heart and your blood vessels, right? So if you're in a shock state and you don't have as good a delivery of oxygen to your cells, and so your cells have a backup system. They can generate energy without oxygen. That's called anaerobic metabolism. And when they do that, they produce lactate. Because lactate can go back to the liver, and through something called the Cori cycle, it can be used to create more energy. So it's a backup system when someone's body is sick. So a lactate level does correlate with how sick and critically ill a patient is. So if someone's lactate is trending up, it keeps going up and up and up and up, that is also a bad sign that someone might be imminently dying. Not necessarily, doesn't mean that they're going to die, but these are signs, these are markers, biomarkers of death. Liver labs can be elevated. So if someone's INR is high, that's a sign of that the liver is not making coagulation factors that the liver makes. We call that the liver doesn't have good synthetic function. It's not synthesizing the things that it needs for the body to function. Other liver labs can also go up. And then also lactate is cleared by the liver. So if the liver's in failure, that's another sign that if the lactate's high, that may be another sign that the liver is also going into failure. If someone's gut is dying, that might be a sign that they're also dying as well, like I mentioned. If they're unable to tolerate like tube feeds going down, because if you eat, if you eat food a bunch of blood rushes to your stomach, and that's kind of why you can feel sleepy after you have a meal. Well, if you're in shock, if you're in a shock state, and we put food in your tube feeds in your gut, and the vessels to your gut might be so vasoconstricted that they start dying as it tries to process the food. So as I said, it's a constellation of findings of multi-organ failure that is trending worse. These are signs that someone may be imminently dying. And then you take all these things in the context of their comorbidities. Maybe they've had heart failure for 5 years. Maybe they've had chronic cirrhosis for a few years. And that we would call this, they're in the end stage of their disease, and this is fine. This is them. They're finally dying. Or maybe they were like my dad. They had pulmonary fibrosis, and they came to their end stage. So it's extremely important as a family member that you have a discussion about. So if someone's in this position, and if it looks like they're going to imminently die, is it the right thing that if they go into cardiac arrest to then pump on their chest and electrify their chest in an attempt to get them back? Is that the right thing to do? Because that's what full code means. Generally, when someone is this sick, it's at this time that I recommend. Families can do whatever they want, but usually I recommend going DNR, do not resuscitate. And I want to make something very clear. DNR does not mean withdrawal of care. We go full force. Okay, we keep going. DNR just means if we lose their pulse, we then stop and we let them pass away peacefully and not violently, which is what chest compressions are. Now, I want to be very clear. There are definitely scenarios where doing chest compressions and resuscitating patient are very appropriate. There are many there are many things that can happen acutely that can be reversible through resuscitation. It all depends on context. It depends on the patient. It depends on why they're going into cardiac arrest. For example, if someone's in the OR and they're getting a laparoscopic surgery, and the surgeon accidentally, we inflate your belly with carbon dioxide, but hey, maybe we accidentally inflated that carbon dioxide into your bloodstream, and you get a huge bolus of, a huge thing of carbon dioxide that goes to your lungs, that causes a cardiac arrest. That person should obviously get chest compression to resuscitate them, and we will likely get them out of that, and they will likely survive. That is a completely different scenario than someone who is in multi-organ failure, who is trending really poorly and is dying in the ICU, right? These are very different scenarios. So context is everything. I do think talking about code status, or DNR, or DNI, which is do not intubate, do not put in a breathing tube, they need to be customized for every single situation. And it needs to be a discussion with the provider and the patient's family, or the patient, if they're able to communicate, what should we do if your heart stops? What should we do? From my perspective, if someone is actively dying, it is at that time appropriate to go DNR, so that if they die peacefully. So what's the difference between DNR and comfort care? These are extremely different things. Comfort care is where we decide to no longer pursue aggressive care to keep someone alive. The way I often present it to patients' families when we're having meetings about what to do for their sick loved one is I present three broad options. There's aggressive care, which is what we're currently doing to keep them alive. There's middle of the road care, which is we keep the course that we're doing. We don't escalate things. Like if they're on pressors, keep the pressors. If they're on antibiotics, keep the antibiotics, but don't escalate anything. If they need a blood transfusion, you don't give them a blood transfusion. That's middle road. And then there's comfort care, which is we actively de-escalate our aggressive therapies, meaning we stop the pressors. We maybe continuing the antibiotics is fine. And again, this is a big discussion, and there's a lot of details. But comfort care, we focus on letting that patient, we focus on their comfort and let them pass away peacefully. And that involves de-escalating the current care that we are giving them. Patients' families often ask, how long do you think they will pass away when we do that? Depending on the scenario, it can definitely be minutes. Sometimes it can be hours, and sometimes it can be days, and they can actually be transferred to the ICU and go to hospice care. I would say often when we are like, they're probably going to die within 10 minutes, we are quite accurate, and they usually do. And the thing to keep in mind with comfort care is that we focus on their comfort. We don't stop medical care. We just change our goals. So instead of giving pressors, we are now starting medications or increasing medications to make them comfortable as they pass away. As someone passes away, they usually have air hunger. They gasp for air. And we want to prevent that because that's unpleasant obviously for the patient, and that's traumatic for the patient's family. So we start drips, powerful medications. We start drips of benzodiazepines like Ativan or midazolam. We start drips of opiates like fentanyl or hydromorphone. And we stand there as they die, and we increase those medications as needed. We watch the patient, and ICU nurses are the best at doing this. We stand there and we give more, and we watch, and we stand and we give more, we give whatever they need. And this is something I've talked about on my TikTok a lot. This is called the double effect. Double effect is an ethical principle where you give an intervention that has a beneficial side effect, effect, and then there's a secondary side effect that is not beneficial. So in this case, the benefit of giving. So let me back it up. An example of the double effect is, say, a woman gives birth, but now is hemorrhaging out of her uterus and is dying. Well, she may need to be emergently taken to the operating room and have a hysterectomy, have her uterus removed, and now she lives. That's the double effect. The positive outcome is that the patient is alive. The negative outcome is that if she wanted to, she no longer have any children through her uterus. Not, obviously she can adopt or do in vitro or something like that. But that's the double effect. Here's the double effect here. We give medications that help the patients be comfortable as they pass away. The negative effect is it is possible it may hasten their underlying disease process. It is possible that they may die faster than if we didn't give those medications. The medications do not directly kill them. Their disease process kills them. But it is possible that they die sooner. And it is ethically acceptable using the double effect. Intent with the double effect is of the utmost importance with this. The intent must be to do good and not bad. So intent matters. The intent is to make them pass away peacefully and not that they die. The intent is what is important. Produced directly by the action, not by the bad effect. Also, the good effect must be reasonably better than what the bad effect is. So in this case, the good effect of having someone not suffer as they pass away is proportionally much better than someone living a little bit longer who is miserable, who is going to die anyway, right? So the good effect is sufficiently desirable to compensate for allowing the bad effect. So anyway, that is what comfort care is. It's allowing someone to pass away peacefully and no longer pursuing life-sustaining measures. We do not do chest compressions. They are DNR by definition if they are comfort care. So when my dad, his diagnosis, with pulmonary fibrosis, it was 3 to 5 years. That's a prognosis. And just right at 3 years, he got admitted to the ICU, for a second time in like a month. And he was put on BiPAP machine, and he was not doing well. And I unfortunately was in another state at that time. But I talked to a critical care physician, which is what I do, and my family was there. And knowing all that I know about how people die, you can probably guess what I told that critical care physician. What did I say? I said, he is DNR, he is DNI, you do not put a breathing tube in. You let him pass away peacefully. And he did. Now, I would have loved him to have a breathing tube in place and extend his life so that I could fly in and say goodbye to him. But that wasn't the right thing for him. Maybe it was the right thing for me. One thing I always say to patients' families is we all know what we want for our loved ones. We want them to live. That's what we want as the providers. That's what the family wants. But they're in a scenario and we're faced with situations where we don't get what we want. And our loved one's dying. It's not what we want. It's not what we planned for. But it is the reality of this life. And it's something that we all have to face. So I hope this discussion helps you reflect on what's important for you and your loved ones, what you want, what are your priorities, if and when these things happen to you or a loved one. A question I get asked often on TikTok and Instagram and stuff is, as someone who sees so many people die, what does it do to me? And honestly, I get dulled to it. I become kind of desensitized to it. I definitely have been like, I'm towards the end of my shift and I have a patient who's dying and I talk to the family and I'm like, hey, I think we should let them go. and we move to comfort care, and I'm there, and then I go home and I don't think about it. I've just done it so many times. It does become routine, and maybe that sounds a bit insensitive or cruel or something like that, but there is absolutely no way that you can work in critical care and internalize every human trauma and injustice and death that comes across my doorstep, because I would become massively depressed and I couldn't function as a human being. You just can't internalize these things. There's no way. There's absolutely no way. So, this human tragedy does roll off your back. It does. And there are times when I'll run a code, and we do chest compressions and try to get a patient back for 30 minutes, and then we don't get the patient, and then sometimes we debrief as staff with nurses, RTs, and everybody, and I look around the room and everybody is crying from the death, and I'm like, I'm thinking about how I need to go. I'm hungry. I need some lunch. And what I mean by that is I've just done it so many times that it just doesn't affect me. That maybe it does for people that haven't done that many. It's usually younger people that maybe haven't been in the field that often, they're new to being exposed. I hope that doesn't come off the wrong way. What I just shared make me sound insensitive. And who knows? Maybe I am insensitive. Maybe I need to reflect on this. But again, it's impossible to do this job if you internalize all of these tragedies every day. Anyway, when I lose a patient or we go to comfort care, I always make sure we do a moment of silence, and I usually always say, it's and sincerely mean it. It's an honor to have treated your loved one, and then I leave the room, and almost never do patients' families want to talk to me again, because the chapter is over. And I think in some way it's in many ways it's a relief, particularly with chronic illness. The chapter has closed, and there's a lifting of the disease burden is gone. And I experienced this with my dad, who was very ill for 3 years. When they pass away, you're grieving for them, but you're also happy for them. I was happy for my dad. He had crap lungs, and he wore that disease well, and he bared it very well with cheer, the same cheer that he always had. But I was relieved for him that he didn't have to suffer anymore. It was a relief, and I'm still happy for him. Still happy for him that he doesn't have to live that way anymore. All right. Why don't we all just take a deep breath? I know that was a very deep, serious discussion. But I hope you've benefited from it. I think that's all I have to say about that. We can talk about death and dying process in much greater detail, and I can do it in further episodes if people have enjoyed this discussion, or maybe not enjoyed it, but have benefited from it. All right, let's shift gears. I'm going to talk about a book. So I'm going to talk about a book that I did not like, and so some criticism sometimes I get, which is a ridiculous criticism, but when I share about book reviews and stuff that I share on TikTok, people are like, "Oh, well, you only read books that you agree with." Like, no, don't make that assumption. I also enjoy reading books that challenge my assumptions and challenge my biases. That's how you grow. And I often seek books like that out. Not every book that I read, but so the book that I'm going to talk about today is called Cynical Theories: How Activist Scholarship Made Everything About Race, Gender, and Identity, and Why This Harms Everybody. This is a joint authorship by Helen Pluckrose and James A. Lindsay. So so this might be a little long-winded, but I think you might enjoy this discussion. So just because I didn't like the book, it doesn't mean I actually learned a lot by reading this book. So I actually recommend this book, even though I didn't like it. So basically what this book is, it's a overstated polemic against liberal intelligentsia. Just kind of sum it up. I did enjoy it more than I thought I would. I had a healthy dose of skepticism coming in, and as it turns out, that's kind of the author's point. And as I said, I really did get a lot of this book, but I believe I have legitimate reasons to not like it. First, so the positive things. In the first quarter of this book, the authors lay out a very detailed and very boring explanation of postmodernism. And that's really what this book is about. And I'm no expert on postmodernism. But from what I understand, it's an academic movement from the mid-20th century, and it's rooted on the premise of deep skepticism and doubting objective truth and common universal concepts of how reality is perceived. Postmodernism fractures classic modern narratives into meta-narratives that question our very reality and argue that truth is based on individual and lived-in experiences, not institutionalized experiences. Postmodernism is basically a radicalized challenge to classic epistemology. The discussion of postmodernism is extremely important, as I said, because that's almost all of their arguments rely on postmodernism. And why is that? It's because the authors argue that modern-day social justice movements are just rebranded postmodernism movements, that, renegade philosophies that have resulted in a cultural authoritarianism and behavior policing with all that, like chilling and unsettling Orwellian implications you can imagine. The authors venture into post-colonialism a little bit as well. So just diving a little deeper, according to the authors, postmodernism social justice movements have pitted radical skepticism against scientific skepticism, supplanting the scientific method with nihilism, which essentially obfuscates science in a quest for cultural conquest rather than scientific triumph. The form of these neo-postmodernism movements are, critical race theory, queer theory, feminism, disabled theory, what the authors called fat studies, which I don't agree with that term. The authors believe that all these group identities have atomized into movements that no longer seek liberal change, but to assert cultural dominance, and that they've culminated in belief akin to a religion. And with these new belief systems, there are, of course, heretics. Anyone who may disagree that, say, sex is a biological fact and not a spectrum, or that not all minority group individuals have the same experience of victimization. All of these movements fall under the umbrella of critical theories, which constantly question the status quo. They assume power structures and white supremacies are covert, ever present, and must constantly be challenged. According to the authors, these critical theories are also post-colonialistic in that they advocate for, quote, research justice, elevating group experience over empirical evidence. And I think there's a lot of merit to a lot of those arguments that they make. Their discussion on critical race theory includes the argument that it advocates black nationalism and trains people to seek racism in every social interaction with impunity and hostility. They clearly suggest white people are victims of critical race theory and that the theory leads to constant confirmation bias in its acolytes who categorize everything based on race and in essence become racist themselves. They argue that critical race theory is likely to tear apart the very fabric of society because it creates tension and racial hostility where it shouldn't really even be there. They also claim that intersectionality of subjugation casts blame solely on white men and makes them the focus of societal problems. They claim that critical race theory engenders white guilt, even on an individual level, and demands white repentance. Critical race theory for them is casting individual and personal responsibility onto white people. And the authors essentially argue that critical race theory subverts prior civil rights achievements and obstructs further meaningful liberal change. Here's the things that I like about this book. As you can tell, I have a lot to say about this book. I agree with the authors that critical theories and how they influence social justice movements have hindered open discourse. I do believe that cancel culture, one of the main impacts that the authors bemoan, is a real problem. People should be forgiven for their mistakes, for their misconceptions, for their misunderstandings. Social justice movements do create a militant attitude toward dissent, creating heretics that don't really exist. And I agree there is a trend of cultural authoritarianism going on in the media, universities, the workplace that ostracizes people for voicing their opinions. Free discourse is required for liberal advancements. And in this sense, critical theories can definitely shoot themselves in the foot. Critical theories could very much be a cultural vehicle for left-wing authoritarianism, which of course is not good. Critical theories are likely in large part responsible for the right-wing authoritarian backlash that we see and the erosion of expert opinion and scientific method. Now, here's my main problem with the book and why it does not get my endorsement. The authors exaggerate overstate and create a false dichotomy between victims of critical theories and actual victims of state and cultural oppression. Here's the meat of the problem, and they don't touch on it at all. There are very real and very disparate outcomes based on race and sex that the authors don't mention even once. This is an actual phenomenon, and there are only two conclusions to draw from the hard data of ongoing inequality. There is either structural subjugation going on, or the victims are to blame for their circumstances. That's it. It's either one of those two options. I do not believe I'm making a false dichotomy. So where do our authors fall? It is very reasonable for me to infer that the authors don't believe that the ongoing inequitable forces in our societies are due to structural power imbalances based on race and sex. And this is highly problematic. It's an attitude that insulates and protects the status quo of oppression. The authors, like many conservatives, rest on the laurels of the civil rights movements and assume that such gains will eventually happen again, but offer no real avenue for it to happen. It's a huge irony that the authors claim that science and data are oppressed under critical theories and don't recognize the cold, hard metrics of very clear disparities of social outcomes based on race. The authors have almost a naive and sanctimonious trust in incremental liberalism. But systemic racism is very, very real, and it is embedded in disparities seen in household income, employment, health outcomes, incarceration rates, intergenerational wealth, the list goes on. This was an enormous oversight by the authors, and it basically invalidates the bulk of all of their arguments. Whatever problems critical theories create are dramatically disproportionate to ongoing racism and sexism in Western society. The authors infer that these are symmetrical problems, but it's very obvious that a white, for example, like a white professor being fired for a tweet, is vastly different from an innocent person of color being shot dead by the police caused by systemic racism. The authors clearly overstate and exaggerate the hindering to science that critical theories can pose. They went as far as saying that critical theories could hinder scientific advancement on a scale of suppressing, silencing someone like Albert Einstein. It's totally absurd. I don't believe the authors are radical right-wingers. They're not. But I did find their smug condescension quite ironic, given that this is something they vehemently are opposed to in academia. The crux of their arguments rests on postmodernism, and that's their greatest weakness. Yes, postmodernism might be influencing current critical theories, but the only proof of this is academic conjecture. And even if there is like nihilistic influences of social justice movements, you can't just throw out the baby with the bathwater and assume that liberal democracy will clean up the mess when it's on a foundation that is deeply inequitable from the very beginning. Imagine applying these authors' approach to Palestinian apartheid. It's like laughable to even think that such an impotent approach would do anything for such severely subjugated people as the Palestinians. It would seem like the authors asked subjugated people to wait and suffer while liberal technocrats sort things out. It's not how it works. The meat of the book is it's just an academic fight. It's not a real fight that average everyday people need to really be worried about. They do not offer tangible solutions other than suggesting inherent trust in an ill-defined liberal incrementalism, and they really only obfuscate real struggle. The question is, how did prior civil rights advancements even arise? I would argue it was challenging existing power structures, which critical theories do, that leverage cultural change into legislative change. Change comes from protest and rebellion against structural oppression, and I don't think the authors understand this. Critical theories are just that. They're theories. They're imperfect models, and they're based on imperfect social sciences. That does not mean that they are not helpful and cannot bring about meaningful change. At the same time, we should all be careful of becoming militant social justice warrior zealots, creating enemies and heretics where they don't exist. That is the valuable warning of this book, but I found the rest to be mostly just full of academic grievances that aren't really applicable to real struggle. All right, well, so that was a mouthful of that book. I don't know if anybody really cared about all of that I had to say about that. Let me know if that was too much. If you want that much analysis from a book, or if you enjoyed that, let me know. And to repeat, that book was called Cynical Theories by Helen Pluckrose and James A. Lindsay. All right, let's finish off this episode answering some questions. All right, this first question comes from TikTok user Tana McLellan, and they ask, how do you swallow saliva without choking while you're under anesthesia? So that's a good question. So if you're under general anesthesia, so general anesthesia is you are, typically very deep. Now, general anesthesia, you usually have a breathing tube, but not necessarily. A general anesthesia is basically defined as someone who is unresponsive while they're under. Now, you don't have to have a breathing tube to be unresponsive. That definition varies a lot, and that definition is also always not super well understood. But if you have a breathing tube, and you're not swallowing, basically the saliva is just pooling. It's just pooling in the back of your throat. So that's why before we wake you up, we suction the back of your throat out really well. Because obviously we don't want that saliva being pooled in the back of your throat when we take out the breathing tube, because you could aspirate a bunch of saliva. And then otherwise, if you don't have a breathing tube and you're deeply sedated, we're monitoring. There's always someone there, either a nurse anesthetist or an anesthesiologist, and we're monitoring for sounds of like gurgling and things like that. So we can suction your mouth out even while you're asleep. And then you probably have some degree of swallowing mechanism if you're on a lighter plane of anesthesia and you're something is going down. But it's not like a huge concern. I mean, it is a concern. We don't want secretions can definitely get in the way. The saliva secretions can get in the way in the breathing tube and things like that. But that's why we have suction. We just suction you really well. All right. Next question up from TikTok is from user PedsRN68. And this person asked, do you do peds cases, meaning pediatrics? Do peds anesthesiologists do additional fellowships? So the answer is yes, I do some pediatrics, but not young kids. And by young, I mean usually less than 10, maybe sometimes like a 9 or 8 year old. Because and you need to be pediatric trained, an extra year of pediatric fellowship if you want to work at a purely pediatric hospital. Now, I do not work at a purely pediatric hospital because I'm not a pediatrician. So the reason it's okay for an anesthesiologist who has not been trained in pediatrics, I've done pediatric during residency, so I got training there, and quite a bit of pediatric training. But if a 10-year-old child, the difference of anesthetic between like a 10-year-old child and a full-grown adult is actually not that huge. It's not like a big gap. Obviously, everything's smaller, and there are some different things with physiology, but the difference is not enormous. Particularly like a 12-year-old or a 15-year-old. The dosing is different, things like that. But it's quite similar to an adult. Now, a baby, I don't do anesthesia for babies. I don't do anesthesia for infants. I would never do that. I would refuse to do it. Well, I would in an emergency, of course, if there was no other option. But I would be like, no, this needs to be done by a pediatric trained anesthesiologist, because now we're getting on different levels. The physiology is quite a bit different. The anatomy is quite a bit different, and the operations are quite a bit different. The types of operations that a baby needs compared to a full-grown adult, they can be vastly different. Like a congenital heart, a baby with a congenital heart problem who needs cardiac surgery, I'm the last person you want in that room helping out with that. So I do a little bit of pediatric, not a whole lot, and I definitely enjoy, of course, working with kids when I have them as patients. It's always nice, but it's not routine. Maybe a couple times a week. Anyway, that's all the time I got for this episode. If you want to ask me questions or tell me what you think of the podcast, you can email me at icudoctorecmo@gmail.com. That's icudoctorecmo, ECMO @gmail.com. You can message me, follow me on TikTok. My handle is at @ICUDoctor. On Instagram, it's @ICUDoctorTikTok. Rate, if you've enjoyed the podcast and if you made it this far to the end of the episode, please rate and review and share the podcast, and I'll see you next time. Thank you.